Thanks, Hannah.
So good afternoon, everybody. It's great to see you all here today. Just to introduce myself and my colleagues, my name is Caroline. I'm a reproductive health nurse here in the UK, and I also work in neglected tropical disease control, NTDs. And a particular area of interest for me is female genital schistosomiasis, otherwise known as FGS, and that's what we're here to talk to you about today, to give you an overview and to talk a little bit about some of the work that we have been doing globally to try and tackle this very, very neglected women's health issue. So I'm just going to go into presentation mode here. So how does FGS occur? For those who may never have heard of it, some of you may already know, and some of you may never have heard of it, which is very, very common. So FGS is a complication of chronic schistosomiasis hematobium infection, otherwise known as bilharzia to many of you. So schistosomiasis itself is both an acute and a chronic disease caused by parasitic worms, which are found in freshwater bodies. The parasite is most commonly found throughout Africa, but it also lives in parts of South America, the Caribbean, the Middle East, and also in Asia. People become infected when the larvae forms of the parasite are released into the water by freshwater snails, and they then penetrate human skin through contact with infested water. So disease transmission occurs through contact with the water where these snails breed, and they then release the parasite, and the parasite burrows through the skin. There are two major forms of schistosomiasis. There's intestinal and urogenital. And we are here today to talk about FGS, which is a urogenital complication of chronic schistosomiasis infection. So symptoms of FGS are caused when these parasite eggs enter the body and become deposited in the uterus, the vaginal wall, the vulva, or the cervix. And chronic infection can lead to inflammation and lesions forming in the reproductive organs. Women and girls in endemic areas become infected following exposure to the parasite in the fresh water through daily activities, so such as livelihoods, swimming, fishing, washing clothes, collecting water, and bathing. So therefore, communities without access to safe water supplies and adequate sanitation are particularly at risk. I have here a diagram which is quite useful for you to see of the anatomy of FGS. You can see, so in the body, the larvae develop into adult worms, adult schistosomes, and these adult schistosomes live in blood vessels where females then release eggs. Some of these eggs are passed out of the body through feces or urine to continue the parasite's life cycle, but also many eggs become trapped in body tissues, which you can see here on the diagram, these little yellow eggs. And they cause an immune reaction, they cause an inflammatory response and progressive damage to organs. So they also affect the urinary tract. You can see here that it affects the bladder and the urethra, as well as the reproductive tract in women. And it also can affect men as well. Complications of FGS. So this is once a woman has been infected with schistosomiasis for a long time. So these are chronic complications, which then lead to female genital schistosomiasis. And these are commonly, typically, abdominal or pelvic pain, disorders of menstruation. We have pain during intercourse or dyspareunia, vaginal bleeding after intercourse, inflammation of reproductive organs, genital lesions, and then sort of more seriously, miscarriage, ectopic pregnancy, and very often infertility as well. So all of these chronic complications lead to enormous stigma for the woman who is affected. And many of these symptoms can also present as an STI. The symptoms are very common and very similar to a sexually transmitted infection, which is why misdiagnosis is so common. And in some communities, this can have quite serious consequences for the woman, such as gender-based violence or social exclusion. So women suffering from FGS are much more likely to experience severe mental health consequences, including depression. In terms of diagnosis, the method for diagnosing schistosomiasis as an infection is relatively simple. It's a urine test where we can detect eggs in a sample of urine using a microscope. But diagnosis of FGS is much more challenging. Diagnosis is most effectively done through vaginal examination, so visual examination of the cervix and also the vaginal wall using a colposcope. But there's very often a lack of expertise to run these diagnostics and a lack of resources. So it makes diagnosis and confirmation of FGS very, very challenging. And current laboratory techniques are also often not appropriate for diagnosing FGS. Clinicians and healthcare workers are generally unaware of FGS in endemic countries because it's very often, in most places, it's not included in training for nurses, midwives, and medics. And very often, therefore, the symptoms are misdiagnosed, resulting in inappropriate and ineffective treatment. This then results in multiple visits to healthcare services, thereby increasing the burden on the healthcare system as well as on the individual herself. And as I mentioned earlier, a frequent reason for misdiagnosis is because symptoms very often are very similar to those of an STI. So this misdiagnosis can lead to the stigmatization of women amongst women and girls who may face judgment for bad behavior, promiscuous behavior, and therefore that leads on to unnecessary treatment and clinical investigations which fail to reverse the symptoms. So physiologically, emotionally, and also socially, women and girls affected suffer a huge amount. This is quite a useful diagram, just talking a little bit about misdiagnosis to help you sort of visualize what's happening. So if we start at the top here where it says A, so the woman affected presents to her local health post, and she then is sent to receive treatment here in B, perhaps at her local pharmacy, where she's most likely treated for an STI because nobody realizes that she has FGS. This leaves her symptoms unchanged and the cycle repeats itself. So she can become stuck in this first cycle. Without resolution, she may be referred to the next level health service. And again, further examination and tests are done. However, it is likely that she'll be treated for an STI again, which does not resolve her symptoms, and the cycle continues again. And so on and so on. And if proper diagnosis were carried out at any one of these points, she would be able to be treated, and therefore her symptoms would greatly improve. In terms of burden and impact, the true burden is actually unknown, but it's estimated to affect 56 million women and girls across sub-Saharan Africa. And estimates show that up to 75% of women who have schistosomiasis, who have bilharzia, also could suffer from symptoms of FGS. And the burden is often high, very high amongst young women, 18 to 29-year-olds. It has also been identified as a leading HIV cofactor in sub-Saharan Africa. So that means that it is associated with a 3 to 4 times higher risk of HIV acquisition and also transmission. So there's a very significant geographic overlap between HIV affected communities and also those with a high prevalence of FGS. Very often adolescent and young women are more vulnerable to HIV infections, to new HIV infection. And this is therefore further compounded by their vulnerability to FGS. The actual causal relationship between HIV and FGS has not yet been fully understood or fully identified, but there are many ongoing studies at the moment, and more research is needed. And data has also shown an association between FGS and HPV, which is the virus that can cause cervical cancer, as FGS of the cervix can affect the body's immunological response to HPV infection. In terms of treatment, praziquantel is used to treat schistosomiasis, and this is available mainly to children in endemic countries through deworming programs, but it's very often not available to adults. Regular treatment with praziquantel kills the adult worms in the body, and therefore the worms no longer produce eggs, and therefore treatment can reduce inflammation of existing lesions, and it can also prevent new lesions from developing in a woman's reproductive tract. Regular treatment with praziquantel from an early age can prevent chronic infection and also associated pathologies such as cervical cancer. It's believed that women treated with praziquantel with deworming tablets at least once in their lifetime, they have a 50% less likely chance of developing FGS. So regular treatment is therefore critical for prevention of infection as well as for cure. And there are no long-term health. Praziquantel is very, very safe and very effective. It can also be used in pregnancy. There are currently some research projects ongoing to look at whether treatment with praziquantel can actually reverse the effects of FGS, whether it can actually reverse these lesions, and also to look at what the optimum dose is. So just to finish off, I want to talk a little bit about the importance of integration, and we'll go on to talk about that more in the next presentation. But as we've seen, FGS is a significant human rights, development, and also reproductive health issue. And therefore, it's really vital that we have a multi-sectoral approach, that multi-sectoral partnerships and integrated programs are needed in endemic areas to ensure that we are using a holistic approach to address FGS. So rather than having programs running in silo, we need to think more about integrating them. So you have your NTD programs linking in with your HIV services linking in with cervical cancer, family planning, maternal child health, etc., etc. So to follow on from this, with this theme of integration, I'm going to introduce my colleague Kazim, who is our research project coordinator for the FAST package based in Canada. And he's going to talk to you a little bit about this pilot project, which has been running for the last 2 years in Ghana and in Madagascar. And over to you, Kazim. Thank you.
All right. Thank you, Caroline. Once again, my name is Kazim Arobudade, and I'm the research project coordinator for the FAST package. And over the next couple of minutes, I'll be providing an overview of how the female genital schistosomiasis accelerated scale together package, also known as the FAST package, is addressing FGS in sub-Saharan Africa. Next slide, please. Next slide, please. So I'll be presenting under the following outline. Next slide. So like Caroline mentioned, the awareness of female genital schistosomiasis at the health system and within the community is lacking. So when women and young girls present for treatment, they are often misdiagnosed as sexually transmitted infection, sending them down the path of stigma, unnecessary investigation, and untreated infections. A 2019 UNAIDS study encourages the preventive treatment with praziquantel as an HIV prevention strategy. However, more work is still needed to be done in the areas of integrating these initiatives and programs. Next slide, please. So the FAST package is currently being implemented in 2 sub-Saharan Africa countries, Ghana and Madagascar precisely. Next slide. So in Ghana, we are currently implementing in Wija and North Tongue districts, while in Madagascar, we are implementing in Morondava and Sakaraha districts. Next slide. So these 4 public health interventions has been proven to be effective on their own. However, the efforts to coordinate these interventions together has not always been effective. Next slide. So the FAST package has pulled together these proven evidence-based intervention in a holistic manner to improve the lives of women and young girls living with FGS. And I'll be talking about each of the components in the next couple of slides. Next slide. Next slide, please. So in terms of diagnosis and treatment, the first package is advocating for using syndromic approach to identify female genital schistosomiasis and treat FGS with praziquantel. But given that mass drug administration with praziquantel is targeting school-age children, the first package is advocating for wider access to praziquantel outside the MDA campaign, that is within the health system. Next slide. So the first package has conducted series of training for healthcare professionals in sub-Saharan Africa, and the training started with the development of core competencies workshop for healthcare providers who perform pelvic examinations and those who do not perform pelvic examination. So in May, June of 2021, the first package, in collaboration with the Geneva Learning Foundation, launched an online training for frontline healthcare workers in about 60 sub-Saharan African countries. And this online training utilized a case-based approach, peer-to-peer learning, and problem-solving strategy within the participants' local context to enhance knowledge and information around FGS within the learning process. But due to the increased demand for knowledge and information around FGS, the first package team conducted face-to-face training on FGS for frontline healthcare providers at the district level in Ghana and Madagascar, and also created a pool of subject matter experts on FGS to address the training needs in the long term. These FGS subject matter experts are motivated scholars, tutors of pre-service institution, district director of health services, and frontline healthcare providers who had completed the online FGS training and impact accelerator events. In the course of this webinar, one of the frontline healthcare providers who is a subject matter expert on FGS will be sharing our experiences with us in the field. Next slide. So in terms of creating awareness at the community level around the risk and impact of female genital schistosomiasis, the first package conducted an assessment at the community level in Ghana, Madagascar, to understand community perception, practices, knowledge, and behavior about female genital schistosomiasis and schistosomiasis, including health-seeking behaviors of people with symptoms of schistosomiasis and FGS. And based on the findings and the knowledge gap, the first package team, in close collaboration with the Ministry of Health in Ghana and Madagascar and the School Health Education Program in Ghana, developed and disseminated schistosomiasis and FGS education booklets. Next slide. So the first package is also trying to align its activities with the National Mass Drug Administration campaigns and supporting MDA through education and training using the first package created resources, including the Schisto and FGS education booklet that are earlier mentioned. And as part of the assessment, the first package also tries to understand the reasons behind the participation and non-participation of community members in current mass drug administration activities, and working in close collaboration with stakeholders to address this challenge. Next slide. So the first package, as part of the component of the first package, central to it is the FGS National Advisory Committees. So these committees comprises of representatives from the Ministry of Health, Ministry of Education, Ministry of Environment, and other departments and activities within the government. And the aim of this committee is to increase communication and collaboration about FGS, as well as integrating FGS into clinical training and existing clinical services such as sexual and reproductive health, family planning, HIV/AIDS, cervical cancer screening, and family health. The FGS National Advisory Committee is being supported by the World Health Organization Afro region and the NTD program in the implementation country serves as the secretariat. Next slide, please. So the first package combines a wide variety of partners at the global, national, and local level. These partners are committed to working together to improving the lives of young girls and women suffering from female genital schistosomiasis. At the global level, the first package launched the Technical Advisory Committee and is working in close collaboration with the NTD program of the World Health Organization. The team members are members of the FGS Community of Practice and the FGS Advocacy Group, also known as FIG. At the national level, the first package is working in close collaboration with the FGS National Advisory Committee, the Ministry of Health, and the clinical training institutions. While at the local level, the first package is partnering with the primary health centers, working in the schools and community level through the NTD program. Next slide, please. So the first package project is a consortium of partners led by Bruyere Research Institute, and other research partners are the University of Health and Allied Sciences in Ghana, the Bridges to Development in USA, and Association Kolo-Banona. The project is funded by Grand Challenges Canada with match funding from the World Health Organization Expanded Special Project for Elimination of Neglected Tropical Diseases, MEC, Global Health Institute, and Core NTD, while the implementation partners are the Ministry of Health in Ghana and Madagascar, the SCI Foundation, and the Geneva Learning Foundation. Next slide. Thank you for listening. So I'll pass it over to the next presenter, who is one of the FGS subject matter experts who will be sharing experiences from the field. Over to you, Ruth.
Thank you very much, Caroline. Thank you very much, Kazim. My name is Ruth Alote, and I'm a nurse in Ghana. I work at the Korle Bu Teaching Hospital. It's one of the Ministry of Health facilities. I'm actually a beneficiary from the series of trainings that the first package have organized. I'm also a product from the Geneva Learning Foundation, and that is where it all started. Had it not been my participation through the activities organized by the Geneva Learning Foundation, this inner passion that I have about FGS wouldn't have materialized. I'm sure there are lots of people here who might not have heard of Ghana before. And if you have heard, the map that is just about showing on your screen will tell you where Ghana is located on the world map. You can also see one of the countries that is very endemic with female genital schistosomiasis is Ghana. Almost every region has recorded cases in FGS. We used to have 10 regions, but currently we have 16 administrative regions, as you can see on the map. Sorry, I can hardly see the slides.
I've shared the slides, Ruth. You should be showing.
Okay, no. Okay.
Kazim,
Okay.
can you see my slides?
Yes, I can see the slides.
Okay. So this is about Ghana and schistosomiasis. Our population is a little above 32 million, and our land size is 238,533 kilometers square. The female population is roughly above 15.3 million. And as I said earlier, we have 16 administrative regions. We are ranked among the top 5 countries in sub-Saharan Africa. Approximately 20 million people are at risk of FGS in Ghana. Next slide, please. As I said earlier, the whole interest about female genital schistosomiasis began with the Geneva Learning Foundation Even though I've taken qualifications in MPH, that is Master of Public Health, schistosomiasis was mentioned, but there wasn't any emphasis on female genital schistosomiasis and how it affects females, it affects girls, women, mothers. I mean, think of everything about females, and this female genital schistosomiasis is causing a lot of havoc. We took courses like the COVID-19 pandemic, immunization issues. We also had courses about vaccine hesitancy, and then we had IA 2030 courses. It is actually through this participation and the peer learning, the facilitator guidance that got us through the online course on female genital schistosomiasis. And through dedication and inner drive to complete the courses, we were able to get this far. Really grateful to the Geneva Learning Foundation and the FAST package for bringing out this great need to help humanity. I was able to participate in the online course, as Kazim said earlier. I was able to also participate in the SME training that was organized in Ghana in February 2002. And this has really opened my mind and has given me the drive to keep on creating awareness on FGS, and also to keep on working around making sure that everyone, every female gets free from this life-debilitating disease. After the training, because I work in the hospital, I made sure everyone around me got to know about the new thing that I've learned. So I sent copies of the report to our CEO, the head of the public health, and also Ops and Gynae unit, where most of these cases will be found. This has led as open way actually for me to have series of presentations on FGS and also interact with other health professionals across the globe. So this is a picture of the training we had in Ghana about female genital schistosomiasis, training for SME, that is subject matter experts. And you can see all the funders in there. To talk about the facility experience, actually, before I got to learn about female genital schistosomiasis, I had come into contact with a man in the hospital who introduced his partner to me and said all the symptoms that were suggestive of sexually transmitted infections. All I did was to refer to the Ops and Gynae unit because I thought that place would be managed better. But unfortunately, with time, he came back to me and said the symptoms remained the same. So it was after I was trained about all that FGS is about, I got to know that might likely be FGS and not a sexually transmitted disease that I thought. I tried to follow up, but we could not trace the woman. That was so sad for me. But after I didn't sit there unconcerned, I kept on discussing female genital schistosomiasis with other healthcare workers within and around Ghana and even beyond. So one of the colleagues I spoke with told me he was once at a community, and at that time, if you are even a woman in that community and you do not donate blood, you are seen as odd within the community. In fact, this statement really didn't allow me to sleep. I took a car, I took bus, got to the place. It was not within where I work, but I traveled to the next region in search of this community. I was able to find the community and notice that there was a river that serves about 7 communities. And all of these community members have experienced female genital schistosomiasis at one point or the other. The females in there, everybody, almost everybody has got his or her shared story to share. I met the chief in the community, and the chief confirmed this statement, but said even now that there are pipe-borne water within the area, some people still feel that the place where the tap waters are too far from where they would have preferred, so they still prefer to use the stream. So the female genital schistosomiasis is still present. So I met with a family of a 10-year-old girl and this girl had female genital schistosomiasis. I met with the father and the mother, but the father wasn't open to talk about it. So there you see the stigma in the still present within the community. The mother was able to tell me more about all that the girl has passed through, but thankfully they've been able to get to the healthcare facility nearby and they have received treatment. So I told them about what they've done and the complications that if they had not, would have led this poor girl into. They were so appreciative and I was so glad I gained this knowledge and still trying to fight on to prevent the infection of female genital schistosomiasis. I think it's very crucial for all of us to come on board and contribute our quota to getting FGS eradicated. Some of the factors that have influenced FGS from the 2 stories that I've shared include support from partners and significant others like parents and other caregivers. Also, knowledge on FGS by the healthcare provider is key, because when I met the first man with a partner, if I really knew, I would have helped that poor woman from all that he's been through and saved the man's money that he has spent without any solution. But I didn't know. So I think knowledge by healthcare workers is key. Also, migration. There are some people who live nearby streams, but because of occupation, because of other factors, they migrate to other areas. And because they are not able to give that history, it becomes difficult treating FGS. And I think it's about time that all healthcare workers, we add location of where people live as part of the biodata that we take, and this will go a long way to help. Also, access to care. If there are no places where people who are infected with female genital schistosomiasis can go and access care, it was not going to help solve the problem. Rather, there should be a place where people know they can get access to care, irrespective of how near it is or how far. They should be aware there's access to care, there's treatment, and they can be helped to solve the situation. Also, level of education. The family that I met, I think the mother had some level of education and said, because I saw my children passing out urine that was bloody, I knew it's just a disease and I took them to the hospital. Had it not been the woman's level of education, I'm sure they might have attributed it to something else. The stigma that is surrounding female genital schistosomiasis is something that we still need to talk about. Some people still don't feel comfortable speaking to someone about this condition. And I think these factors have been key whilst I try to help others solve issues around female genital schistosomiasis. The cultural factors, just like the man said, this area, when you are there and you don't urinate blood or have these symptoms, they see you as odd because everyone else is having it. That was so sad to hear. But thankfully, we are fighting very hard to make sure that this community receives some level of care. So the time is now. All of us need to come on board to create awareness on female genital schistosomiasis. Thank you very much.
Thank you so much, Ruth and Kazim. It was really nice to hear from you and hear your experiences. So now I'm just going to go to I can see we've got some Q&As here in our chat. If I go to the Q&A, so we have the first question: why FGS of the cervix can affect immunological response to HPV infection? This is a really great question. Effectively, once the eggs become lodged in the cervix, they cause this very severe inflammatory response, and therefore, and also immunological response, which means a woman's immune system can be slightly reduced, and therefore she's more susceptible to HPV infection, as well as HIV infection, because she has these, we talked about these lesions around the cervix and the vaginal walls, which can make her more susceptible also to HIV infection. The second question we have here from somebody else: can you suggest any course to improve knowledge and practice in FGS? So we've actually produced, there's a couple of options, and maybe we can put that in the chat. Maybe Kazim, you can share it in the chat. The Fast Package website contains all of the training material and the Q&A document that we produced when we ran these global training workshops. So there's lots and lots of resources for you to read there. And we also, the Nursing Now Network, have also shared a reading list with plenty of material there, so you can improve your knowledge around that. And the third question was around colposcopy training. Absolutely, colposcopy is the kind of gold standard for, at the moment, for diagnosing FGS, when you can actually visualize the cervix, and but you need a colposcope, and you need very good light, and you need the knowledge and skills to be able to perform colposcopy. So that's a very good point. That's a very necessary part of training, but obviously it's not available everywhere. So we need to think a little bit more outside the box about how we can diagnose a woman if we don't have those resources available to us. So I can see, I'm just looking now through the chat. So Hannah, perhaps you can share if there's any questions that I've missed or
yeah. The question around the FGS National Advisory Committee.
Go ahead,
the question goes, can you hear me?
Go ahead.
Okay, the question goes, I would wish to know the composition of the secretariat that Kazim is making reference to, and what is the goal of the secretariat. So the FGS National Advisory Committee comprises of representatives from various divisions of the Ministry of Health, Ministry of Education, and Ministry of Environment. And in Ghana, for example, the FGS National Advisory Committee comprises of representatives from the Disease Control Division, Institutional Care Division, Family Health Division, and the Neglected Tropical Disease Program, and also representative from WHO and the Ministry of Environment. So the goal of these committees is to increase communication and collaboration around female genital schistosomiasis, as well as to facilitate integration of FGS within the clinical training and existing clinical services such as maternal and child health, sexual and reproductive health, family planning, HIV/AIDS, cervical cancer screening, and the likes. So these committees in Ghana have provided regional orientation on FGS to district health personnel, and they were also part of the fast package team that conducted face-to-face training for frontline healthcare providers. They are being supported by WHO Afro region, and they are also conducting training on female genital schistosomiasis beyond the implementation districts of the fast package. And they were also part of the team that developed and disseminated the Schisto and FGS education booklet that I mentioned. So that is basically it. If you want to learn more, you can reach out to us for more information. Thank you.
Thank you so much, Kazim. I thought perhaps now we could pass to our colleague Cecilia, our panel, Cecilia and also Rashid, maybe to introduce yourselves and to say a little bit about where you work and also your knowledge and understanding of FGS in your own areas of practice would be wonderful. Cecilia, do you want to start?
Yeah, sure. Good evening, everyone. My name is Cecilia Ndongo, and registered nurse in Kenya. And currently, I'm the co-chair for the Nursing Now Challenge in the region, that is the Afro region. And in fact, this is a very timely and very educative topic. In Africa, and especially in Kenya, we have an endemic area around the Lake Victoria, whereby mostly some of these cases are usually go unrecorded, or maybe what you've just learned, they're usually misdiagnosed. And so it will be good if all these programs are integrated in the HIV programs, and also train. There's a need for training for colposcopy, the diagnosis for the healthcare workers, and especially the nurses and the midwives in reproductive health sector. Thank you.
Thank you so much, Cecilia. It's great to have you join us today. I'm just going to pass now to Rashid. Would you like to introduce yourself and talk a bit about where you work and your experience of FGS? Over to you, Rashid.
Yes, thank you so much. Sorry, I'm not going to share my screen because I have unstable network connection. So I apologize for that. My name is Rashid Manganda. I work as registered nurse from Malawi and Columbia District Hospital. I'm also a co-chair of African Health Challenges Committee. I work hand in hand with Cecilia. So today I'm just going to share a little bit of why it is difficult for nurses in Malawi to recognize FGS. So even myself, when Hannah sent me a link to join this webinar, I was even not sure what FGS is. So I deliberately did a simple survey. I asked my fellow nurses across Malawi, in different parts of Malawi, just to find out how many nurses are aware of FGS. I'm sad to tell you that out of 20 nurses, only 2 nurses had a little bit of knowledge of FGS, which is a very serious problem, very serious gap here in Malawi. So why is it difficult for nurses? Given the nature of the signs and symptoms of FGS, women tend to approach health services with complaints of infertility or symptoms of STI here in Malawi. So clinicians are generally unaware, nurses are generally unaware because it is not, as Karen has already said, it is not described in medical textbooks or nursing textbooks. Even the laboratory diagnostics are inadequate here in Malawi. So it is really difficult for us to identify or to isolate FGS. Consequently, for women of reproductive age living in areas, endemic areas like lake shores here in Malawi, FGS remains highly prevalent and diagnosed here in Malawi. So what nurses can do to improve or to raise awareness? This is, I think, the most part that we need to concentrate because it is really a problem here in Malawi. Yeah, so I have a few suggestions that we can do as nurses to improve or to raise awareness. I think FGS topics should be included in the routine continuous professional development sessions that we do as in different countries. Here in Malawi, we do routine CPD sessions, yeah, monthly, each and every facility. So we have facility-based and online-based. So FGS topics should be included in those CPD sessions. Nurses and midwives should also organize or facilitate quarterly webinars to talk about FGS so that they can be able to handle it adequately. Nurse educators or midwives should also lobby for FGS inclusion in nursing curriculum. There's also a need to raise awareness in the communities. For people in the community to recognize FGS, they need to have the knowledge. So what can we do for us to impart knowledge in these people in the communities? So there's a need to do engagement meetings with local leaders, to involve school communities, or to give out information about FGS through mobile vans. So there are a lot of ways that we can do to raise awareness in the community. In addition to that, FGS topics should be included in daily health education in different clinics, such as antenatal care clinics, family planning clinics, sexually transmitted infection clinics, even cervical cancer screening clinics. There we can be able to reach out to a lot of women to give them information about FGS. There's also need to do education in lake shores. Here in Malawi, we have a lot of lakes where we have a lot of visitors that come to visit the country. There, we meet a lot of visitors that are not aware of this FGS. So as nurses, we also need to take a toll to educate these travelers maybe also to offer them Vasquante was a prophylaxis or prevention myth. So there are a lot of things that we can do as nurses. I think for the interest of time, I may wish to stop there. Thank you so much.
Thank you so much, Rashid. I think you made some really valid points, particularly about raising awareness in the community, as well as with healthcare professionals. And I think what's become very clear over the last couple of years and the work that we've been doing is that it can be as simple as you want it to be. So we're not trying to reinvent the wheel, but it's really about thinking, how can we integrate this awareness raising and this improved diagnostics and treatment for FGS into existing services, existing platforms. So we don't need to create a whole new service, but we need to think about how we can integrate into services that are already existing in country. There's a question, or there was a question in the chat from Martin. I believe Ruth has just answered it about where are the integration points and how is FGS reported through the health system. Ruth, perhaps you can say a little bit about how you report through the health system in Ghana now.
Okay, thank you very much. We used not to have FGS on the district health management systems, but currently there is a slot in there for you to record the number of FGS cases that you see at wherever facility that you are. And I think that is great, because if there's no place to report, then even when you see the case, you just handle it. And if you are not there, no one gets to know about it. But with this, wherever you sit, you can see the number of cases that are being seen at a point in time. Yeah, thank you.
Thank you, Ruth. And I know there was another question in the Q&A about somebody was asking for more clarification on how FGS can cause infertility. And I think, Ruth, you also responded to that. So as one of our SMEs, do you want to respond to everybody on that question? Because there might be others who are also asking the same question. If you are there, Ruth, can you hear me? Are you still there? Maybe she dropped. Okay, no problem. So the question was just to clarify more about how FGS can cause infertility. So basically, as we discussed earlier, once those eggs become trapped in body tissue, so the schistosome eggs released by the adult worms in the body, they become trapped in body tissue and they cause this inflammatory response. That can also cause scarring of the fallopian tubes, and that's why infertility is a chronic complication of FGS. But this is, you know, once a woman has been infected for quite a long time and it's been left untreated. We have come across cases of women who had tried to have children for many years. In fact, there's a case here in the UK, somebody that I worked with who visited Malawi, and she swam in Lake Malawi, and she then became diagnosed with FGS. She couldn't have children. She was then diagnosed a few years later. She was treated with praziquantel, with the deworming tablets, and she now has 3 children. So there are cases where it can be reversed, but we are not sure, and the research is ongoing into exactly how effective treatment is at reversing the effects of FGS. We don't quite know yet, and it's not always going to be successful. There's a question in the chat here from Cecilia. Could we have an online course on FGS to be made available to nurses in our academy in Kenya? So Cecilia, at the moment, all the training material is on the Fast Package website, which Kazim shared in the chat. So if you go and have a look on there, we don't have any online training courses planned at the moment, but this hopefully will change. But there's lots and lots of reading material that your nurses can access through the Fast Package website. I hope this answers your question. So we have no more questions in the Q&A. Oh, no, we do. So there's a question about the FGS of the cervix affecting the response. So we talked about that it can reduce a woman's immune response to infection, and therefore she's more susceptible to infection. It can also damage the surface of the cervix. So if she becomes infected with the HPV virus, it becomes more difficult for her to then get rid of that virus, which some women can do with HPV, and it can then develop much quicker into cervical cancer. The risk is higher, basically. I'm just looking in the chat. for any other questions that I missed. Maybe Kazim or Hannah, you can let me know. I think we've answered them all. Searching through. Kazim.
Okay, thank you, Caroline. Just to add to the question on indicators. So one of the challenges that the FAST package has encountered is documenting FGS cases. Like Ruth mentioned that in Ghana, there is an indicator to capture genital schistosomiasis within the district health information system. But in Madagascar, currently there is no indicator to capture FGS within the health information system. So part of what the FAST package is doing, particularly the National FGS Advisory Committee, like I mentioned earlier, is to integrate FGS within the national health system. And in doing so, this also involves the district health information system and also working with the NTD Department of WHO to integrate this indicator within the system. Thank you.
Thank you so much, Kazim. Just to let you know that I've shared a link in the chat as well. There's an article on the link between FGS and HPV. For those of you who'd like to read a bit more, I've shared that in the chat as well. So please do have a look on there. There's a question here from Alan. Hi, Alan, in the questionnaire. Initially, syndromic treatment was emphasized and now colposcopy. Can you clarify if women with suspected FGS should be presumptively treated or wait for formal diagnosis? So Alan, thank you. This is a fantastic question. So what we've done, we talked a bit about colposcopy and how it's not always appropriate or available, particularly in very rural areas. So what we are now, many countries are now thinking about is what we call syndromic treatment. So if a woman presents with symptoms and she lives in an endemic area and she has access to those water sources that may be infested with schistosomiasis infection, with the parasite, we can then treat her with what we call presumptive treatment. So we assume, we're thinking, okay, she lives in an endemic area, it's very likely that she's come into contact with the parasite and she may well have developed FGS because of her symptoms, and we talked about the symptoms earlier. Therefore, we can treat her with praziquantel. It's very safe, it's very effective. We don't need to wait for a formal diagnosis. And this is what now many countries are looking at moving forward, is this idea of presumptive treatment. If you're seeing these women, you have this very, very high, we call index of suspicion that she may well have FGS. Absolutely, if you have the drug available, if you have praziquantel, treat her 100%. And also it's worth thinking about all the other females who live in her community, in her family, who may have access to the same water source. They would also need treatment. Great question, Alan, thank you. So I think we'll draw into a close unless there are any other questions, which I've missed. Thank you so much, everybody, for attending and your attendance and also your questions, which were good and keep us on our toes and help us to think as well. We've heard from some really great speakers today. Thank you to Kazim for taking us through the FAST project, and to Ruth for talking about your experiences in the field and also with the training. It's really great to hear. Thank you to Cecilia for joining us from Kenya, and to Rashid from Malawi. I'm just going to pass over to Hannah before we close, just to briefly talk about the challenge that will be launched at the end of this week. I don't know if you want to say a little bit about that, Hannah.
Hi everyone, it's Hannah here. No, I think we'll, if we catch up after this call, Caroline, and we can, well, if everyone stay tuned, there'll be some exciting news about a new Nursing Now Challenge Global Solutions Initiative that we'll be launching at the end of this week, all about FGS. So stay tuned.
Thanks, Hannah. So thank you so much, everybody. It was great to see you all. And please do access those materials and those resources on the FAST package website, because there's a lot of information there for you to read and to pass and to share with your colleagues in particular in your area of practice. So please do go and spread the word, and keep watching for more information. Thanks so much, everybody. Bye-bye.
Bye. Thank you. Bye-bye.